Hello, my name is Marianne Borer from HIMSS, and welcome to today's webinar. Thank you for taking time to be here today. We have an exciting program for you, but before we get started, I want to highlight a few things so that you'll know how to participate in today's event. At the bottom of your screen are multiple application engagement tools you can use. All of these engagement tools are resizable and movable, so feel free to move them around to get the most out of your desktop space. If you need technical support during today's event, click the question mark icon in the navigation menu at the bottom of your screen where you'll find answers to frequently asked questions, or you can type your question in the Q&A widget to the right of the media player. You can use that same box to submit questions for our speaker anytime, and if we don't get to your question today, we'll follow up with you offline. Engage with today's content and let us know how you're feeling with the emoji reactions. If you miss anything, don't worry. You will receive an email within 24 hours with a link to the on-demand recording when it becomes available. So now, let's get started with today's program. The APIs are the easy part, maximizing your ROI on CMS, prior authorization, and interoperability requirements, sponsored by InterSystems. Our speaker today is Stephen Berkow, Senior Advisor, Value-Based Care at InterSystems. Welcome, Stephen.
Thanks a lot, Marianne. And I want to thank everybody on the line for giving me some time today and for for asking us to talk about CMS's new requirements for prior authorization and interoperability, better known as Rule 0057. Now, before I delve deep into 0057, I do want to just step back for a second and put that rule in context because it's by no means a one and done. Actually, this push towards automating the exchange of information in healthcare through kind of the modern way it's done in other sectors like travel and finance through APIs is very much bipartisan and part of an ongoing push. So, for example, back in 2020, you have an earlier rule called 9115, and if you look at that, there is a call for a FHIR-based patient access API, a mandate for that. Now, as many people know, there wasn't as much utilization of this API as was hoped for, but nonetheless, it very much serves as the foundation for what happens in 0057. So for now, the expanded use of the patient access API and for other APIs, for APIs enabling payers to query previous payers about a member's health information, providers being able to query plans about information about their payers, and kind of the big one at the bottom, the automation of prior authorization, which is actually not one API, it's multiple APIs. So these are both CMS rules, but if you actually go on to very recently ASTP-ONC, which is the entity that actually certifies health IT, so certifies that EHR meet the requirements for providers who are using them to maximize their reimbursement under certain federal reimbursement programs, now beginning to call for a parallel set of APIs within the EHR. I'm going to touch on that a little bit later, but let's go ahead and double click on 0057. This is my kind of 500,000 foot view of what 0057 requires. Just a couple of things I want people to note there. If you run across the middle of the slide, you can see that yes, there is an API requirement within each one of these data sharing scenarios, but it's not just the APIs, right? It's not all about the APIs. There's associated requirements for changes in business and operational processes. Two other things I want people to know. If you are a payer, much of the ROI that you can get from enabling kind of compliance with 0057 via payer to payer is not as the sender of the information as the recipient of the information. So if payers on the line, very important for you to wear two hats. What am I going to need to do to comply to share the information via payer to payer? What am I going to need to do to take advantage of that information coming into me to maximizing my ROI? The last thing I want to underscore is I've very deliberately used the word exchange for prior authorization on the far right, as opposed to data sharing. because EPA really is, electronic prior authorization really is more complex. So when you look at the first three scenarios, it is more of a one-way sharing of information. Either the patient or the other payer or a provider is requesting information, and then a health plan is providing the requested information. Prior authorization requires a back and a forth and a back and a forth. So you really have to figure out how to automate a true conversation. Now, in light of time, I am going to focus my remarks on payer-to-payer and electronic prior authorization, but I am going to offer some resources at the end for people who want to delve deeper into the requirements around patient and provider. Before we get going here, I have two introductory slides. First, I do want to acknowledge that I bring a bit of bias to this conversation. So InterSystems is a global leader in healthcare interoperability with special expertise in unlocking the power of clinical data. So on the slide, it's just a snapshot of some of the customers we serve in North America. Looking in the middle, you can see we serve health plans. So not surprisingly, we have a full suite of solutions for 0057. But I also want to encourage everybody to look around, right? We're powering Epic. We serve a number of providers, a number of HIEs and QHINs. And so even though we are biased towards using technology to solve healthcare challenges, we're not biased towards any one segment of the healthcare industry. And at least personally, I found this incredibly helpful as we've started to think through how can we support electronic prior authorization, because as I've talked about, this has to be a conversation among several key stakeholders to be effective. The other kind of framing slide is just a couple of points to ensure people don't forget the forest as we get more into the trees. The first one is 0057 technically governs impacted payers, which is a defined term in the rule. And I've listed them out here, but kind of just to keep it simple, it's basically everybody but traditional Medicare and commercial plans that are offered by employers. Now, that said, I will tell you that there's a growing number of industry-led initiatives and state laws that are already expanding, particularly the provisions pertaining to electronic prior authorization, EPA, beyond impacted payers. So we're already starting to see kind of a halo effect of the rule beyond impacted payers. Second, very important to remember that APIs are not a user interface. I actually want to read the definition here. For purposes of CMS 0057, an API is a set of commands, functions, protocols, or tools that enable other software developers to create programs or apps that can interact with software utilized by the payer without needing to know the software's internal workings. So what does all that mean? So I just want people to think about other industries for a second. So let's think about travel. An API is not Kayak. It's not travel.com. That's the user interface. What the API does is it enables that user interface to readily go get the information from other places without having to actually know how those systems are working. Those informations are easily publicly discoverable. And that's what this mandate is about. Lastly, I want to delineate between the rule and the recommended IGs. So the rule definitely mandates that plans support a number of FHIR-based APIs. In the rule, the DaVinci IGs or implementation guides are highly recommended as the roadmap for how to stand up those APIs, how to effectuate this transfer of information via APIs. And this is an important delineation because a number of plans have to figure out what is the right glide path for their organization. So there's certain things you must do by the effective days, certain things that are highly recommended. Now, let me be clear. InterSystems is both a member of and a huge proponent of Da Vinci, which is a payer, provider, vendor, government collaborative. We believe that this is the right path. But again, we are working with our clients to figure out there's certain things you have to do. There's certain things you definitely want to do, but exactly when you want to do them, you have a little bit more flexibility on. All right, let's go ahead and get into electronic prior authorization. So this is my one slide cheat sheet for what the rule requires for EPA. And I know some of you are probably already drifting over to the right, looking at those tech provisions and the APIs, but I want to kind of drag you back to the left for a moment because there are a number of mandates concerning timeliness and transparency that are really right around the corner. The effective date is 1/1/26. So for example, dropping down to the middle of the slide, response timeframes. CMS really putting out a target benchmark for the maximum within which a prior authorization should be adjudicated. So 72 hours for expedited requests, 7 calendar days for standard requests. Important to note, there is no mechanism for auto approval if the payer exceeds the deadline. The hammer here, in effect, is public reporting, transparency. You can see down at the bottom, plans actually have to report at the outset of next year on how they're doing right now. So you really begin to feel how close this is. Even though APIs and all these things that are going to help speed prior authorization haven't been mandated, plans are going to have to report on how they're doing on a number of prior authorization measures pertaining to timeliness and outcome at the outset of next year for how you're doing right now. All right, let's switch over to the right side. At the heart, as we've alluded to, at the heart of the EPA provisions of 0057 is this requirement for APIs that, in effect, speed the answers to 3 questions. Providers should be able to query an API to find out, is prior authorization for this procedure or service even required? If it is required, what's the documentation I need to submit to get approval? And finally, to facilitate the electronic processing of the request if I choose to go forward. So 3 big questions, and the rule highly recommends 3 Da Vinci IGs, which align with each of those. They're called the burden reduction IGs for actually how plans are supposed to build this out: CRD, DTR, and PAS. One other thing I want to call out before I leave this slide is everything we've been talking about is about what plans are required to do. There is one requirement with regard to providers, and that if they want to maximize, again, their reimbursement under certain federal programs, they have to attest, yes, that in effect, they processed at least one prior authorization request via EPA. So, important to note, providers are required to try it. But if we're really going to transform how we do EPA, it is important to keep in mind that we've got to build this out in a way that providers try it and then want to keep using it. All right, I do want to touch on HTI-4 again. Like I said, it's pretty clear which way the winds are blowing. Even though there's certain things that haven't been mandated yet, the government keeps layering on this push towards electronic prior authorization via API. So HTI-4, again, this is from ASTP ONC, so the government entity that actually certifies organizations as certified health IT. And what they did under HTI-4 is they added 3 new modules for certifying health IT for, in effect, CRD. You can see it, coverage requirements discovery, that's CRD, DTR, document templates and rules, and prior authorization support. And the bit of confusion out there is that although they've added these modules, they have not yet added certification on these modules into what's called the base definition of an EHR. So how these help is if a provider is wondering, hey, wait a minute, if I process an EPA using my EHR, can I definitely attest that I'm doing this pursuant to EPA as outlined by 0057? And the answer is yes. But again, 0057 highly recommends the Da Vinci IGs. It doesn't require it, which leaves a good bit of wiggle room. But there is a fair likelihood that over time, this will ultimately be incorporated into the base definition. So let's take a look at how information will flow under these three IGs and talk a little bit about where are the opportunities to really maximize the ROI for both providers and health plans. So I'm going to start on the left. So the whole process starts within the EHR. And for those unfamiliar with prior authorization, this is huge. Actually, the way most prior authorizations start today is via phone and fax. Most health plans have a portal that a back office member of a provider could go into to trigger a prior authorization. But what we've heard time and again from providers is they want this workflow to be within the EHR. So they don't have to step out of kind of their natural workflow for helping patients, that they can trigger the prior auth within the EHR, and that will launch the CRD. 4 pieces of information critical for the plan to be able to determine whether a prior auth is required. Nice thing, the system should be able to look for those electronically, and then hopefully populate them electronically if they're missing. So streamlining, 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 and then get back to the provider in a matter of seconds, ultimately under the CRD IG. And this is a huge potential value for both the plan and the provider, because what we've seen from pilots is upwards of 80% of prior authorization requests. The answer is no prior auth required. So number one, provider gets this information up front, often when their patient is even within their office still. Number two, no need to go through the whole burdensome process of marshaling all the necessary evidence to submit the prior auth. And this is good for the provider, but also for the plan, because right up front, we short-sighted a lot of work for both plan and provider. I think what's emerging now is that there's a second huge potential point of value for providers, and that when that what's called the CRD card comes back, the electronic answer, is prior authorization required, there is an opportunity to provide additional information. So you can see kind of a mock-up that we've been working with some of our customers with. You can provide a clinical suggestion. You could also say, hey, you know what? This image is already available. Will that do? What's really interesting, though, is where providers and payers are now realizing there's another huge potential point of value here. What providers would really value is if there's a test or if there's a question or something that can be addressed before their patient leaves their office, to pull that forward, even though it's not required by the IG. That's the type of tweak that's going to make providers really want to migrate to electronic prior authorization. All right, let's keep going. So assuming that prior authorization is required and the provider and the patient want to move forward, then you launch the DTR, the next IG, and then it's going to pull in electronically everything the system learned from CRD. And this is really important. Retrieve what's called a questionnaire, which ideally is written in CQL. So what is the questionnaire? So the questionnaire is the statement of provider. This is the documentation that you need to submit in support of this prior authorization request. done right, a huge satisfier for providers. One of the big frustrations on the provider side is uncertainty about, okay, well, actually, what do I need to submit? And all too often getting back a prior auth was denied, not for clinical reasons, but because documentation is missing. Even better, there's now a standard called CQL. It's a FHIR language to query the EHR for information, which takes me down to the next thing. And then ideally, this questionnaire, the responses can be pre-populated automatically from the EHR. How far we can go down that road immediately is somewhat dependent upon how equipped an individual EHR is to answer questions via CQL. One other thing I think people need to be cognizant of is what is the difference between an adaptive form and a standard form. The process can handle both. But many purveyors of medical rules, the way it's structured, the prior auth, they ask for some information, then they need more information, and that's called an adaptive form. Another huge potential satisfier for providers, because instead of having to fill out all the information up front, they can answer a couple of questions. It can be very, very focused. Ultimately, your system, though, has to support both, because whether it's an adaptive form or a standard form is going to be dependent upon the purveyor of the medical rule. Once everything is available, again, electronically, you can start the process by launching the next IG PAS. And then one thing I do want to note at the bottom, although technically not required by 0057, we're including something called CDEX, which is another FHIR standard in our 0057 solution, because we recognize that a number of the attachments that are commonly submitted in support of a prior authorization request are going to go beyond the complexity that CQL can handle. And via CDEX, it will be a way for a plan to electronically query a provider and get the response back electronically. So you can see why this is so attractive, a tremendous opportunities by following these three IGs to automate burdensome and time-consuming processes for both providers and plans. But as Marianne mentioned at the outset of this, it's not just about the APIs. If you're going to really maximize the return on this investment you have to make under 0057, it's important to think beyond the APIs. So let me orient you to what I call my EPA game board. So in the middle, the gray column, I wrote CMS mandated APIs. That is what is mandated under 0057. We like to call it the digital front door, that plans have to support the set of APIs that can be easily queried by an EHR or a third-party app to answer those three big questions. Is prior authorization required? What documentation do you need? And actually, please go ahead and process this request. If you add CDEX to that, then that's what we offer through what we call payer services. But if you go down to the bottom, you see that we are working with our customers well beyond just what's mandated by 0057, because you're going to have to get utilization and the ability to kind of get administrative savings. They're really beyond not just the scope of the rule, but beyond the scope of the IGs. So let's look left for a second. If we are going to get utilization, obviously we have to build something that providers see value in, but we have to make it readily available to all the providers in a plan's network. And often, there's thousands of providers within a plan's network. So down at the bottom, you can see the portal. That's kind of what's currently already out there. And we know through the continued dominance of fax and phone not getting the uptake. There are a number of plans who are working with health systems that serve a disproportionate number of their members, or vice versa. There are some providers who are working one-off with some plans who ensure a disproportionate number of their patients to create that direct connectivity or native functionality from the EHR to the plan APIs, so that conversation can have electronically. And we're supporting that. I mean, as many people know, again, we're the technology that powers Epic, so we're doing a lot of work there. I think ultimately, though, the big aspiration is, can we create some electronic hubs? At the center of this is HIMSS, and we're working on this too. Examples are where the technology powering the Blue Cross Blue Shield Interoperability Hub, and a product now being rolled out by eHealth Exchange, one of the bigger QHINs, called the EPA proxy app. So that's something you want to think about too. If you're the plan, how am I going to be able to efficiently scale my connectivity to all the providers in my network, or at least the subset of providers who account for the dominant share of my members, or vice versa? If you're a provider and you want to really start to pull forward use of EPA, how am I going to connect to the plans that ensure the dominant share of my patients? On the other side, as we talked about, a lot of the investment that's being mandated by 0057 falls upon the plans. So I think it's really, really important also for the plan to be able to realize administrative savings. And over on the right is my simplified, very simplified version of all the different systems and processes that get touched at a typical prior authorization within a plan. And one of the keys to kind of uncorking that efficiency on the plan side is connecting all those back-end systems and processes electronically to that digital front door. And so we're doing a lot of work with plan customers to figure out what is the right mapping. And it's really important that you have an API manager or router that you can in effect program in sophisticated business rules, so that when things come in through the digital front door, no human being is necessary to route that to the appropriate system to get the information that can come back and go over to the provider side. So as I've intimated, we are really kind of up to our eyeballs in helping plans stand up their 0057 solutions. So before I leave EPA, I did at least want to share what I call no regrets moves that I think everybody should be making now. That's very much informed by what we're seeing work from our early implementers. So number one, encourage people to expand your mapping of current PA processes to include impacted systems and people in common workarounds. The why behind this is, even though we've been talking about a lot of technical challenges, actually the number one barrier that people come up against is kind of just good old-fashioned resistance to change. And what we're seeing is that if the plan can be really cognizant of the people who are impacted and all kind of the difficult things they're doing to get around the existing processes, and then be able to draw a line to show how moving to EPA will make this better, they're far more likely to start to get champions and support. Number two, keep what's required versus recommended by CMS 0057 top of mind when staging rollout of EPA. Again, there's certain things plans must do by 1/1/27. And then there's this roadmap that is definitely right answer within the Da Vinci IGs. There's a lot that has to happen between now and the outset of 2027. And I think what's most important, and we've heard this again and again from provider leaders, that what you plan roll out into the marketplace, most importantly, it has to work. You're only going to get one or two bites of the apple before providers start to form their opinions. So better to roll something out that works, provides immediate value for the providers, and then begin to layer on more and more functionality than roll something out that is problematic. And the government's actually done a nice job of establishing a framework. Hey, here's certain things that you have to have in place by 1/1/27, and here's the right roadmap, but you have some wiggle room in terms of, well, you roll out everything. Number 3, invest in a high-performance API manager and data integration engine. We already touched on the API manager. I think the reason why you still have to think about that data integration engine is if you are plan a lot of your back-end systems, they still don't speak FHIR, or they speak a different dialect of FHIR. So it's important to be able to transform that into kind of a common or a canonical format of FHIR, so that information can flow through the API back to the provider. Number 4, focus first on leveraging your 80/20s to capture efficiencies from digitization of medical policies to plan provider communication flows. This is kind of the corollary to the second bullet point. But when you start to look at the stuff that's highly recommended, you really want to leverage your 80/20s in terms of making the calls of what do you try to pull forward. Really think about what are the services and procedures that disproportionately account for your prior authorization requests. And ironically, think about what are the things that are easier to digitize, right? Because the more volume that we can pull forward, the better. And then over time, we can get to the tougher stuff that actually accounts for a smaller percentage of your prior authorization requests. Number 5, apply proven tenets of change management, meet key stakeholders where they are at, and rely on trusted influencers to bring their peers along. So if you're thinking about, right, phone and fax, right, it's been awfully hard to displace. And I don't think it's realistically to think we're going to flip a switch on 1/2/27 and everybody's going to embrace EPA. I think what we need to acknowledge, whether we're talking about driving utilization among providers, we need to delight highly respected providers who will then bring along other providers. And then the same thing in terms of even within the plan, in terms of getting people in the various departments to embrace this change of process. You have to be sure that you're working closely with the key influencers within those departments, and then rely on them to bring their peers along. It's going to be hard for IT to convince everybody that this is the right path. Lastly, ensure you don't have to ask providers repeatedly for clinical information previously shared. And in light of time, I actually think we can illustrate this one even better if we talk a little bit about the payer-to-payer data sharing requirement. So let's move on to that. So here's my snapshot of the payer-to-payer API requirements. So January 1, 2027 deadline. Wide-ranging data elements. So this is not just about sharing information about adjudicated claims and encounter data. There's actually an overlap between the information that's now going to be captured on prior authorization, and at least some prior authorization information is also going to have to be shared when payers exchange information with other payers. Prompt data sharing requests. Payers are 1/1/27 actually obligated to ask their members or patients within a week whether they want them to go get this information from a prior or a concurrent payer. So just 2 notes here. You're going to start to hear when we talk about payer-to-payer, you're looking at it, PDEX. That is the Da Vinci implementation guide that governs the sharing of information from payers. And within that, there are provisions on bulk. And that's very important because payers are going to be obligated to share this information in bulk because so much of the change in plans happens during open season. So unless payers are able to share and ingest this information in bulk, we're not going to get to where the government is really pushing. And that is to integrate this information into a member's record so it can facilitate care continuity. So again, don't get lost between the forest and the trees. There's a lot to do there, but there's a really good end, because one of the things that we know is a tremendous amount of care gaps result when a patient changes or a member changes plans. So one of the first things you're going to have to think through is, how are you going to build on top of your existing 9115 solution? And the reason for that is that the data requirements for payer-to-payer build on the provisions in 9115 for the patient access API. And looking across the screen, I've tried to call that out. You can see embedded in not just payer-to-payer, but also provider access is the data that has been being captured for the patient access APIs with some logical additions and subtractions. Now, when you're thinking about this, one thing you have to keep in mind is you just can't build off your existing solution for 9115. That's going to have to be upgraded. And you can kind of get a sense of that by 0057 is also expanding what's required for the patient access API. So you got to be sure that you've upgraded your 9115 solution, and then you build on top of it. All right, let's get into some of the operational things you have to do. So there's a whole slew of them here as well, just like with regard to EPA. So members have the option for opting in. We alluded to this earlier. But what does this mean for you as a health plan? You have to put in place a process to basically ask members and record whether they want to exercise their opt-in rights, which means you're also going to have to stand up a consent management system. Also, in the US, we don't have a universal member ID or a universal patient ID, which means that you have to collect the necessary information from your member to identify a prior or concurrent payer. And then you actually have to engage in stand up a member matching system to ensure that based on that information, that the other plan, hey, I'm talking about the same person. We got a match here. And information updates, quick note, if this scenario is for a concurrent plan or payer, you're actually going to have to do this on a 90-day cycle. But going back to our conversation about ROI and what we're really trying to accomplish here, I think what you have to just keep top of mind is you can do all these things, but you're still not going to get to kind of that big ROI that what we're trying to accomplish here, and that is to close disruptions in care continuity. Let me illustrate my point. So there down there is the payer-to-payer API. And one of the things you have to start thinking about is, as this information comes in, where are you putting it? Because yes, it comes in as FHIR, but it's a FHIR bundle. And what we're seeing time and again, the plans we're serving is when they open up that FHIR bundle, there's CCDA, there's flat files, there's all these things in it. So it's a mound of information. So if you're actually going to achieve the desired use case here, you can see it in the red box, ensuring the continuity of care, you've got to be able to parse that information. You've got to be able to make it ready for use so your care managers can deploy it. And one of the things that we talk about is you also shouldn't just be thinking about single use, because time and again, what we hear from providers, for providers on the line, is you get frustrated when a payer keeps asking you for the same information for different use cases. So if we're really going to optimize this exchange of information, I think we also have to start thinking about, are we being good curators of the information that we're getting? On the next slide, I share with you what I call our starter scorecard for assessing LHR capabilities. It is actually a list of requirements that we hold our own LHR up to, what we call the Unified Care Record. And in light of time, I'm going to leave this for your later review. You can reach me at stephen.berkow@intersystems.com. Happy to provide more information on what we see as essential in a longitudinal health record to truly advance value-based care, to truly get to that point where you can ingest information from one source and use it for many use cases, including optimizing continuity of care. But to simplify things, I'm just going to leave everybody with one of my favorite comic strips. I think if we're going to advance value-based care, we've got to stop this. And what, again, we've heard time and time again is it's not just the patients who get frustrated with having to provide the same information again and again. Everybody does. I just think it's, again, back to my point, we've really got to be sure that when you think about 0057, definitely with payer to payer, and even with electronic prior authorization, it's not just about sending information out. Increasingly, more and more information is going to be coming in electronically. It's important that we be good stewards about how we capture and curate that information to address the immediate use case that is intended behind 0057 and to advance the larger push behind 0057 to improve value-based care. So I promised that I would give you a resource. So for people who want to delve deeper, we actually recently updated our white paper on 0057. Just did it. So even if you've looked at this before, I encourage you to download it. It goes through not just payer to payer and EPA, but it also gets into the detail of provider data sharing and patient data sharing. And with that, I think might have a little bit of time for questions. I think I went a little long.
Yes, thank you, Stephen, for a wonderful presentation. I want to remind our audience that you can continue to submit your questions in the Q&A window to the right of the media player. We have a few that have come in already. So here's our first question. Will EHRs be able to pre-populate answers to questionnaires sent via DTR APIs, or will this work essentially still land on providers?
That's a great question. So I think long term, yes. I think right out of the gate, it depends upon the EHR. So different EHRs are taking different approaches to how quickly they stand up their ability to ingest. Remember, I talked to them, those CQL queries, the FHIR query language that they could respond to electronically. But I still think there's tremendous savings for the provider just in terms of being able to know upfront this is what is required for documentation. And for EHRs or the user interfaces, even where everything can't be auto-populated, what we're seeing is the use of forms to dramatically streamline a provider's ability to respond within that EHR workflow.
Terrific. And here's our second question. Do all medical guidelines need to be rewritten in machine readable language by 1127?
Oh, no. And that gets into kind of that 80-20 conversation and what's required versus what's recommended. I wouldn't want anybody to kind of feel like they can't start taking advantage of this because they haven't digitized every medical rule that they use. What is important, what must be in machine readable language by 1127 is a response to that question of what documentation is required. And we call it a questionnaire, but sometimes it can be a question, but it also could just be a statement of, I need these medical notes. Now, rolling forward, one of the advantages of the more and more of these rules that get digitized, it opens up the possibility for adjudicating with AI. So over time, it's right answer, and that's what we're heading. But you don't need to be there on 1127 to start getting huge benefits for both the payer and the provider.
Excellent. It looks like we have time for one more question. Does 0057 mandate that plans have an LHR?
So it does not technically mandate it. As a matter of fact, a couple of industry analysts have referred to the LHR, the longitudinal health record, as the implied fifth requirement. And it goes back to the requirements that I quickly laid out under the payer-to-payer information sharing. And the expectation from the government that the information a payer receives gets incorporated into the member's medical record in such a fashion that that information can then be leveraged to improve care continuity. And so the reason why people refer to it as the implied fifth requirement is it's really hard to see how you can get to that impact unless you have a true LHR as opposed to just a data lake where you have all this information and it's not kind of ready for use by a care management system.
I see. At this time, we do have to wrap up. Thanks again to you, Stephen, for all of your insights.
Thank you.
And once again, we would like to thank our sponsor, InterSystems, for their support of this webinar. For our audience, don't forget to take our brief evaluation at the end of today's event and share your thoughts with us. As a reminder, you'll receive an email within 24 hours to re-watch the on-demand recording of today's session, and it'll be available in the HIMSS Resource Hub for a limited time, so feel free to come back and watch it anytime. Thanks, everyone, and have a terrific rest of your day.